So hello and welcome to the LGBT and bipolar webinar on suicidal thinking. My name is Talen. So before I get started, I'm just going to kind of go through the kind of housekeeping and the welcome slide with you all. So these webinars will be discussing suicide. So if you need to leave the webinar at any stage, please feel free to do so, and you can watch later via our website. You will not be able to unmute your microphone during the session, nor turn on the video during the session. For these webinars, our chat function is off as questions have been pre-submitted via the community. If you'd like more support during or after today's webinar, you can email our support team at info@bipolaruk.org. So the webinar is going to be recorded, and we'll upload the recording to our website, and we'll send out to all registered attendees after the event. If you or someone you care for needs urgent support or help, we have created a list of crisis support resources here at www.bipolaruk.org/crisis-support. You can also email us on info@bipolaruk.org. So I'm going to stop sharing because I need to be able to split my screen really quickly. So I'm going to be your host this afternoon. My name is Dr. Talen Wright, and I am the postdoctoral research manager for Bipolar UK. Prior to joining Bipolar UK, I finished my PhD at UCL in psychiatric epidemiology and investigated the association between microaggressions and depression, anxiety, and suicidality in the trans community. Now I work with Dr. Tanya Gergel to deliver several research projects on bipolar, with a focus on ensuring best practice co-production. I'm a trans woman and I use she, her pronouns, and I have lived experience of both depression and suicidality. So I'm joined today by Lauren, Chris, and Gabriella. I'm sure they'll be introducing themselves during their respective slots, so I won't ask them to do that now. After the talks, we'll come back together and discuss some of the questions that have been submitted. So just to start, I'm going to throw some statistics at you. But first, what is suicidal thinking? Well, suicidal thinking, otherwise known as suicidal ideation, consists of thoughts of ending one's own life, commonly symptomatic of those with depression, but also in bipolar. In a recent Bipolar UK survey, 90% of people reported experiencing suicidal thoughts, and approximately 15 to 20% of people with bipolar die by suicide, with 30 to 60% having at least one suicide attempt. The Trevor Project reported that 45% of LGBT youth had seriously considered suicide in the previous year, with trans youth having an increased risk. According to the Depression and Bipolar Support Alliance, approximately 29% of lesbian, gay, and bi youth reported a suicide attempt compared to 6% of their heterosexual peers. For trans people, mental ill health is common, with 88% having experienced depression and 75% experiencing anxiety. And this statistic was taken from the Trans Mental Health Study in 2012. And with regards to suicidal thinking, in my own study, I found that 91.5% of participants had thought about ending their life, 40% had made an attempt, and 78% had engaged in non-suicidal self-harm. However, the question remains, I suppose, what could lead to this increased risk? So what may be some of the driving factors? And this is where I kind of want to get into it a little bit, because we know for people, particularly with bipolar and for also LGBT people, there are increased risks of suicidality. However, what is driving this? Well, one theory is the minority stress theory. And this theory was first reported by Virginia Brooks in 1981 and applied to lesbian women, and subsequently by Ian Mayer in the 90s. And it states that those from minority populations experience additional stresses that are not experienced by the general population, and that these minority stresses contribute to the increased risk of mental health problems. So when we're thinking about this, we're thinking discrimination, stigma, microaggressions, prejudice, expectations of rejection, disclosure or concealment of identity, and internalized stigma. So what's really, I think, quite interesting about this theory is that these experiences are likely to be chronic. So they're going to be present throughout most people's lives and they're going to be happening on a regular basis quite frequently. So this leads to issues such as loneliness and potentially suicidality due to those sorts of additional stresses. We also have the interpersonal theory of suicide. So this theory refers to two concepts. We have thwarted belongingness and perceived burdensomeness. So thwarted belongingness is the feeling of being alone or disconnected from others and feeling that lack of reciprocal care that you might expect. Whereas perceived burdensomeness refers to the feeling of being a burden on those that one cares about. And these together often increase the risk of suicide. In LGBT people, the interpersonal theory of suicide has been linked to increased suicidal behavior. Feeling as if one is alone and a burden is a commonplace feeling, particularly for LGBT youth who find themselves isolated from the wider community and maybe feeling rejection from peers and from family. Together with minority stress experiences such as discrimination, stigma, and microaggressions, this may explain the heightened risk. And finally, I just kind of want to touch base on maybe some of the other social determinants of mental health. So what is a social determinant? A social determinant, very simply put, is the sort of social issues or social factors that contribute to health outcomes. And the framework itself says that the social, cultural, political, economic, commercial, and environmental factors that shape the conditions in which people are born, grow, live, work, and age in society all contribute to health outcomes. So when we're talking about this, we're thinking about what people are experiencing within their schooling life, within their home lives, and what the governments are doing to protect those who are at risk for poor mental health outcomes. So that was a kind of whistle-stop tour, I think, of some of the theories and the statistics, which I think are very interesting, but I think they'd be much more interesting to hear from our other speakers about some of their experiences. So I need to be reminded, who am I handing over to? I think it's
I
Chris.
think it's me first. Yeah, thanks, Talen.
Hello, Chris.
Hi, Talen. Yeah, my name's Chris Pratt. I was diagnosed with bipolar disorder at the age of 19 in 2003. Later on, I came out as gay at the age of 27. Yeah, I'm also a champion for ending stigma Surrey. And I also help lead a bipolar group for the Mary Frances Trust, which starts again next month. But yeah, over the last few years, I've also been telling my story on my own personal blog and on social media about my experience, particularly around bipolar. Yeah, I was invited to contribute to this session. And I suppose I want to start with a bit of a confession. The long and the short of it is that whilst I've got lived experience of both being bipolar and being gay, I'm also very fortunate that my experience hasn't included thoughts of suicide. So after I very enthusiastically agreed to contribute to this session for Bipolar UK, I must admit I wasn't entirely sure what I was going to say for some time, but just hearing some of the statistics ahead of this session and the statistics which Talen has just shared with us, what I realise is that I'm in that lucky 10% of the bipolar community that hasn't experienced suicidal thinking. I'm in that 55% of the LGBT community that hasn't experienced suicidal thinking either. So that itself I thought was very interesting, and it got me thinking, well, okay, so why is that, right? What's different about me, my life, my experience of these things that's kept me safe? Is it my biology? Is it just the way I am? Or is it the way that I think? Or has it been external factors? Or I don't know, maybe it's just down to luck, right? Am I just lucky? Um, so I started thinking about these things, and I thought, well, do we actually have control over some of these things? Can we influence our thinking? Can we influence our environment to make it safer so that we're able to avoid these terrible thoughts when we're unwell? So I thought, yeah, maybe there's things here that we could all learn from. So that's what I started to explore, and it's what I started to think about. So I suppose, first of all, my credentials as such. As I said, I was diagnosed with bipolar in 2003 when I was 19. I was in hospital for a month on that occasion, over a month. And since then, yeah, I've had a number of other serious relapses over the last 20 years or so that have involved hospital stays. The worst one, I was there for about 3 months. And in between, of course, there's been other sort of blips which haven't needed hospital treatment, but I've also been able to stay well for some very long periods, 11 years in one case. But I suppose the reason I'm saying all this is because I think it's important for my story that, you know, I'm not using the term bipolar in some sort of lightweight and trendy way. I know it sometimes gets sort of thrown around in celebrity culture, and you know, in some cases you would think, well, it's not surprising, you know, I might not have experienced suicidal thinking, but you know, I really do have a serious case of this condition, and it's affected my life in some profound ways. So yeah, I have experienced deep depressions and probably should have experienced suicidal thinking at some point, but I haven't. So I want to talk more about my most recent relapse, which was only a few years ago, back in 2020. And as usual with these things, my mood went high. I entered into a manic phase and I was admitted to hospital in the middle of the COVID crisis. When I got discharged home, I knew what to expect, and I was getting myself ready for a big drop in mood, you know, because I was just expecting that depressive phase of the condition to take hold. But this time, things could be different, because I wondered, would it be possible to recover without dropping into a depression? And the conditions were actually quite good. The weather was fantastic. I'd just been sent home at the end of July in the middle of what would turn out to be one of the best summers in recent memory. I still had a job, which was very fortunate about. So I was receiving sick pay, which meant the bills were paid. But most importantly, and I think this was the most important factor, was that I had form. I'd been ill with this before, and importantly, I'd recovered. So yeah, I set out to have a great summer, and I'm pleased to report I actually achieved my goal. I managed to recover from a major bipolar episode without a depression. And this is how I did it. The first thing was, I knew that I'd recovered from this before, and I knew with certainty that I would be able to do it again. When things got difficult, I would say to myself, look, I've had this before, I've recovered from this before, and I'll do it again. And it became my mantra. But there's a few other things that were quite important. Like I did not allow feelings of guilt or blame. And there's a few things here. I didn't waste time dwelling on the embarrassing or the unkind things that I might have done or said during my manic phase. I just let go of the past and I forgave myself. After all, you know, it was the illness, it was not me. And sometimes that was quite hard. The other thing was I didn't blame others. So although it felt like there were certain individuals that might have contributed towards me getting ill, I forgave them. Not because their behaviour was okay, but it was to allow me to move on. And then I didn't blame myself. It's an illness, and in the same way, it's not our fault when we get a cold. It's not our fault when we get ill with bipolar. What else? I've also got a very supportive partner. Jason deserves not only a shout out, but I think a medal for sticking with me through it all. And I've got some amazing friends. One friend, in fact, invited me away camping later that summer. And he just treated me like he normally would. You know, we were able to laugh and joke as though I wasn't in the middle of a mental health recovery. And he just enabled me to forget about it. He got me out of my comfort zone, doing stuff I wouldn't normally do. And it really just helped me get my confidence back. Exercise was another factor. This was something I wasn't really doing much of, if at all, before. But then I started getting out on my bike pretty much every day, and I'd go for hours. And I discovered this huge expanse of nature reserve and parkland really close to where I live. So it was exercise and getting out in nature. And I kind of discovered at that point that cycling is my happy place. And I think we all need to work out what that is for us. But for me, getting out on my bike, that's where I can recharge, and I can recharge my well-being. I also started learning more about it. So I started a reading habit, learning about bipolar well-being, learning about other people's stories. I got onto Prime and Netflix, and I would have a documentary afternoon. There's loads of good stuff on there. But the next bit was to learn more about me, what's going on with me, and the way that I'm feeling. So I started writing journals every few days, and it just helped me get my thoughts out of my head, get stuff in order, and really helped me to understand myself better and learn who I was. I also gave myself time. I suppose I didn't feel a rush to get back to things. You know, it was important to recover and to get better. And then finally, I started to open up and started sharing my story. First of all, it was anonymously with the Mary Frances Trust. I started doing blogs for them that were just under my first name. And yeah, in remarkably quick time, certainly compared to recovery before, I got better and I felt back to normal. I mean, yeah, I had bad days through there, but generally, I managed to avoid that depression. But it also made me realise that there were things I needed to learn about myself to help reduce my risk of getting ill. I realised that I had to take responsibility for my condition, and that actually I do hold quite a lot of power for preventing a relapse and reducing the seriousness of it if it does occur. And there's also things that I can do to recover more quickly. But there were some other things that I learned. Like I had to learn to read my body, knowing what were those early warning signs and when to spot them. Dealing with the shame and the stigma, and that's been tough. But what I learned was that most of the stigma was from within. What I discovered when I actually opened up and told people was they were very understanding and often appreciative of my honesty. Not only that, they would then follow up by sharing a story that of either personal experience or someone they know that's affected them in some way. But I think mainly, you know, the big thing was around accepting who I am and owning it. And I took a big decision, which I thought very long and hard about. And eventually I went public with my diagnosis 2 years ago. I got involved with End Stigma Surrey. I started a blog. I started putting things on social media. And I've also had some other sort of TV, radio appearances since then. But yeah, that was a big decision. And fortunately, so far, none of the fears that I did have before going public have actually come to pass. It's been a positive journey, which has really helped me. So really, just to sort of wrap up, really, I mean, that's how it's been for me. There's a mix of elements there which have been key to my success and have helped me avoid suicidal thinking. And I think some indeed are probably down to luck, but I think we can influence many of the factors. So yeah, fundamentally, it's about accepting that whether we like it or not, we're stuck with this thing, and you've got to make the best of it, and that can be hard. It can be really, really hard, and it takes time. I think we've got to take responsibility for ourselves and make changes to our lives to just reduce that likelihood of illness and increasing the probability and speed of recovery when it does. It's about finding that right support and knowing ourselves better and just making those protective lifestyle changes. So yeah, I mean, I think everyone here is, you know, is obviously here to learn more about bipolar in context of sort of LGBT and how it affects others. And I think my question to everyone on this call is that, you know, the next thing to do is to learn more about you. You know, I want to know what's your story. You know, if you were asked to speak in this presentation, what would you say? And if, you know, what's holding you back from doing that? Particularly, I think if it's feelings of shame and stigma, what could you do to overcome that? And I think that would be, you know, very, very helpful to start thinking about. So that's what I really want to say, really. I mean, yeah, stay strong. Know that bipolar does not need to define us. We can and we should live full and enjoyable lives. And don't let anyone stop you, particularly yourself. So that's me. Thank you.
Thank you, Chris. I think what you something you mentioned just briefly was the cycling. Because I'm also an avid cycler. I cycle
Oh, excellent.
regularly, um, and there is something so wonderful about kind of freedom of cycling. I find it's just kind of being able to go where you want to go.
Yeah.
But I think that kind of in terms of what I was saying before, with these sort of like really high, prevalence of suicidality, and especially with the LGBT community, I think that, and you're right in a way, a lot of it comes down to sort of a lack of fundamental support, from a partner, from family, from friends, from wider society, wherever it may be, is finding that sort of that niche that kind of helps kind of contain you, I suppose, is kind of like how I see things sometimes. It seems that seems to be a pretty big driver. So I'm really glad that you have that. Um, so thank you again for sharing your story. And next up, we have, I believe it's Lauren next with Papyrus. Hi, Lauren.
Hi, and yes, thanks so much for sharing your story, Chris, and being so open and honest. I'm not someone that has bipolar myself. I have that privilege to not, but I actually do have another diagnosed mental health condition, and I'm LGBTQ, so I can kind of relate to the feelings of shame and stigma, and in my own journey I've overcome that, and it's helped me a lot as well. So yeah, just to touch on that and say, there are, I can speak to being LGBTQ, and I have had thoughts of suicide before and been bereaved by suicide, but I don't have personal experiences with bipolar, albeit I have supported family and friends who do have it, but can't speak from personal experience. But what I'm here to touch on today is more about, if you do have thoughts of suicide, if that does crop up for you, where you can go to for support. So yeah, as has been mentioned, my name is Lauren, and my pronouns are she, her, and I am a community development officer for Papyrus, prevention of young suicide. So we're a young suicide prevention charity, which I'll talk in a bit more detail about in a moment. But yeah, my role at Papyrus is I'm a community development officer. So what that means is I run lots of training in suicide prevention. I do lots of raising awareness talks, and I represent the charity at different events and at webinars just like this one. So that's a bit more about me. And about the charity. So the charity was first set up in 1997 by a mother called Jean Kerr, who unfortunately lost her son to suicide. And Jean got together with other like-minded parents who had also lost their children to suicide. And at the time, they became the Parents Association of the Prevention of Young Suicide, hence the acronym Papyrus, which we know of it as today. Our support is mainly focused around those aged 35 and under. And the reason we honour that age range is when that charity was first set up and those young people were lost, that the oldest was 34 and the youngest was 13, and so that's why we honour that age range. And there's many different ways in which we prevent young suicide today. So first off, we support. So our main line of support is our helpline, which is floating above my head here throughout this webinar. So this is a 24-hour helpline. So any young person thinking about suicide can give us a call and get support with that. Or if you're ever concerned about someone that they might be thinking about suicide, but you're not sure what to do or how to have that conversation with them, you can also give us a call and we can give you professional guidance with that too. It can also be used as a debriefing service. So maybe you've had a conversation with someone about their thoughts of suicide, and that's understandably had quite a big impact on you, and you want to get some reassurances around that. So you can also call us in that situation, talk to someone maybe a bit more removed from that, and get that reassurance. So It has a multitude of functions. And we also equip the community. So this is where my role comes in. So we equip society and communities with the skills and tools to be able to open up more about suicide and support someone who is thinking about suicide through the training sessions that we run. So this goes from like a half an hour talk about who we are, what we do, and how to use our services, to a 2-day in-person suicide prevention course. Suicide first aid course. So that's how we equip, and again, go to lots of different events, raise awareness via those means as well. And we also influence. So we influence on a local and national level. We work with local and national government to change suicide policy. We run a lot of our own campaigns around the subject. So there's lots of different videos on our YouTube channel, on our Instagram, on our TikTok, if you want to have a look at those and yeah, see how they might relate. And we have lots of different resources and information that people can tap into on our website. It's all free to download and use. And there is actually an LGBTQ leaflet on our website if you wanted to have a look through that as well. So a little bit more about our helpline, because that is, the way that is most accessed through support. And before I go into that as well, just to say, I think this was mentioned at the beginning, but we are talking about suicide throughout this webinar, and our personal experiences too. And this might touch on things that you can relate to, or that is touches on things in your own life. So do take care of yourself. Your well-being is paramount. If you need to take a step away from the screen, please do. We all are talking about it in as a sensitive a manner as possible, but we'll understand if you find some of the content distressing and need to take that moment. So yes, just to kind of go through where we might support people who are LGBTQ and do have bipolar as well. There is a case study that I'm going to share with you about someone that called our helpline who did identify with both of these and reached out for support. So someone did call our helpline and shared that they were struggling with thoughts of suicide due to their mental health worsening and due to also a transphobic attack that they had experienced. They explained that they didn't want to report that because they didn't want to provide evidence in court. They also shared that they had a diagnosis of bipolar and had been working to manage their own mental health by taking ownership of their well-being and by putting things in place that will help keep themselves safe. They had previously taken steps to try and end their life and didn't want to do that again. So that's why they called us, and the caller and helpline advisor worked together to create a safety plan that they could access through HopeLink. So just to explain a bit more about what HopeLink is, it's a online version of the safety plan that the person and the helpline advisor go through to keep themselves safe, so they can access that afterwards via a private link that is shared with them so that they can look at their safety plans. So that just goes to show that lives are being saved that relate to these experiences. Other quotes that have been picked up on through calls from people who do have those overlapping identities and could be relatable to yourselves as well is a caller expressed that they feel trapped in a body that they didn't want. Someone else expressed that they'd been hypomanic for a while now but were crashing and feeling really low, and that they really wanted help and needed help. a mum also called us concerned about their daughter, who had recently come out as gay, but who was experiencing issues with a man since coming out as that. So yeah, again, just to say, you know, this goes to show that our helpline, you know, all kinds of people from all walks of life call us. And, you know, we always come at it from as non-judgmental approach as possible. So, and we can tailor our support as and where necessary, but, you know, we're open to all, including those from the LGBTQ community and who also identify as bipolar. So something else to also know about the helpline is there is a translation service available. So if English isn't someone's first language, then they'll get a translator onto the call. There is also a BSL service. So if someone's deaf or hard of hearing, they can get a sign language interpreter onto the call, which is then facilitated via a video call, and that link can also be found on our website. So there are other options available as well. And, you know, helpline advisors do go through rigorous training. So not only in suicide first aid, which is what is the premise for the safety plan that they go through with callers, but also training in, you know, LGBTQ inclusivity, cultural competence and things like that, to have more understanding of people's experiences who call the helpline. And, you know, a helpline suicide prevention advisor is someone who will, you know, they will ask clearly and directly if someone's been thinking about suicide. You know, they'll take you and what you have to say seriously. They'll give you space to talk about things that might be impacting your thoughts of suicide. They're not going to be shocked by anything that you share. They will advise and support you with your thoughts of suicide. And, you know, the main goal is to help keep you safe by developing a safety plan with you. And, you know, the helpline advisors themselves all come from their own experiences and own backgrounds and cultures, which obviously give them a varied context of understanding about different people from different walks of life. And, you know, you might want to know more about what those are, but the conversation is very much focused on you and how we can keep you safe in regards to your thoughts of suicide. So they don't often share personal information about themselves. And, you know, we are a short-term service, so our focus is about keeping you safe for now. And, you know, we will explore within that conversation what longer-term support might be available. And all of it is about empowering callers and helping them to find the strength and confidence to engage with that long-term support that might be available to them, and where we might have discussed about signposting them to. And, you know, helpline advisors undertake sensitive and a compassionate approach to all callers. So, you know, we may have callers who are LGBTQIA+, others who have bipolar, and like in the case studies that were shared, you know, have an overlap of those identities. You know, helpline advisors listen to people's concern without judgment, and their main objective is to keep that person safe for now. So, you know, if someone is experiencing a manic or psychotic episode, helpline advisors might adjust how much they lead the conversation. So we tend to call this guidance. So it's the kind of amount of authority or leadership that is needed in that part of the conversation, and, you know, adjust their approach as necessary on the caller's capacity to participate as well. So, you know, as being discussed throughout this webinar, we understand that LGBTQIA and bipolar communities are unfortunately at higher risk of suicide. We are proud as an organisation to offer that accessible support to these groups and be there in that time of need. So hopefully that's given you a good overview of who we are, what we do, and how you can use us if you ever do think about suicide or are concerned that someone else might be. So that's it from me. So I think I'm passing over to Gabriella now to share some other words and thoughts too.
Thank you. Yes, I'll introduce myself. So I'm Gabriella, and I'm a proud member of the LGBTQ community. I identify as a lesbian, and my pronouns are she, her, and I came out about 6 years ago. It was like a lifetime, in 2018. And I'm also a member of the Bipolar UK community. I'm currently in the process of working with the team to set up an LGBTQ support group, which there'll be more info online ASAP, which I'm super excited about. Yeah, and I live in Berlin at the moment, and I work with a number of different NGOs doing, each one does slightly different things, but I'm also very nerdy about psychology. And so I was thrilled actually when I was asked to speak and share my interests and knowledge and passion today. So I want to go through a couple of different topics today and share some statistics and my opinions and stuff like this. The first one I want to talk about is actually the intersection between bipolar and mental illness in general and being queer. And Talen, you touched on a lot of this actually. I think I'll be able to not cross over, but hopefully I'll add to what you're saying, what you said. But yeah, there's a Canadian study which I was reading yesterday, and I can send the link later, which basically said that the risk for mood disorders is 1.5 times higher in the queer population, which obviously adds to vulnerability, and also there's a trigger risk. And I think, in my opinion, there's a number of issues that come up here that, again, Talen, you touched on. One is isolation. When anyone experiences mental illness or symptoms of any mental illness, it's incredibly isolating. And even if you are lucky enough to be, which a lot of people sadly aren't, in a community where there is a support group or different communities in your life which can support you, when you're going through it, it still feels so isolating. It still feels like you're the only person that experiences this. And obviously, as a consequence of that, some people have a tendency to do the opposite of what is needed, which is self-isolate and feel like you can only take care of yourself. And I think this is a big vulnerability which comes with being in both these communities. And also I feel like lack of emotional and physical safety is a big one, which I'll touch on a little bit later. And then of course the stigma, family rejection, high risk of addiction is a big one. I've been sober now for nearly 2 years, and that's something that I will come to later. And also lack of funding. I mean, again, I'll come to this in a bit, but mental illness is inherently political, and the situation in the UK at the moment is diabolical. And I'm observing from afar because I live in Germany, and actually the general political, I won't comment on that, Germany is like horrific, but the state healthcare system is a lot better, objectively and also in my experience. And yeah, it's awful, the state of the NHS in the UK. And that does come from, as I say, it's inherently political. It does come from the Prime Minister's transphobia, homophobia, all of this. And another thing I think is interesting, the section for me is the absurdly long time to diagnosis for bipolar. I mean, at the moment in the UK, it's 9 years. And if you present atypically, it's even longer. And of course, especially when resources are very scarce in the UK particularly, then if you're presenting atypically, if you need more case-to-case treatment, if you're under 18, there's like even longer. And I think this is even more of a risk, especially as, I mean, I came out when I was like 22. Some people come out a lot later, but I think children and teenagers are coming out, which is beautiful, younger and younger. But of course, there's these other risks that maybe they're also developing bipolar, but they have no idea. And I think things can compound together quite drastically when you suddenly do develop bipolar and start cycling over a few years, and then something you're dealing with your queerness, and I think all can compound and be quite scary. But yeah, I touched on just briefly lack of emotional and physical safety. And I think here the power of community, which I'll come to again later, is paramount as a form of support and a form of healing. Because the thing with, especially the risk of physical safety, which obviously is interconnected with emotional safety, like I believe anyway, and I do, this is statistically backed up, like queerness on the surface now in society seem to be so accepted. I mean, it's even almost come into pop culture, this whole thing at the moment, like the lesbian renaissance is happening. And there's so much corporate virtue signaling. For example, you see HSBC sponsoring a pride, and it just doesn't reflect in reality. And I've got a few stats here to kind of give some context to that. So the EU Agency for Fundamental Rights took a survey of over 100k LGBTQ people, intersex, trans, non-binary, gender diverse, everyone. And of course, in the intersex, trans, non-binary, and gender diverse community in particular, they face a lot more harassment and violence, and therefore, as a consequence, are much more likely to face mental health issues and suicidal thoughts. But the general statistic for discrimination, for example, across the survey was that 1 in 3 face discrimination in their daily life. 1 in 10 experienced violence than the 5 years before the survey, which was more than the survey in 2019. Over 1 in 3 intersex people were attacked. Over 1 in 2 victims have experienced hate crime. This was 1 in 3 in 2019. 2 in 3 said they were bullied at school. This is again a steep increase from 1 in 2 in 2019, and 1 in 3 have contemplated suicide. And over half of the trans, non-binary, and gender diverse people in this study, so over 50k, said they've had suicidal thoughts. And the last one is about conversion practices. I mean, actually, when I was researching all of this, I was like so horrified by, not surprised, but so horrified by these statistics. But this one really got me. It's 1 in 4 say they were forced to go through conversion practices in 2024 in Europe. I mean, it's just horrific. Yeah, and like, I really actually want to bring it back to what I just mentioned, was about how it's inherently political. And as most of us on this webinar might have seen, Rishi Sunak, no longer the Prime Minister, as we know, has been making comments for years. And in October 2023, he said that we shouldn't be bullied. It's ironic, for believing that that bullied into believing that people can be any sex they want to be. Obviously, when Brianna Ghey sadly was murdered, he utilized that to politicize against Keir Starmer, which is disgraceful. Keir Starmer, I think, also used a little bit his opinions for virtue signaling, when actually, in reality, he said a lot about how gender ideology should not be taught in schools. And yeah, it goes on. And actually, this study that I was just referencing to from the EU Agency for Fundamental Rights, also one of the stats that came out of that was that 1 in 4 consider that their governments are trying to combat prejudice, which is only 25%. It should be more, really. And I think that's also very reflective. Yeah, I mean, I have more that I could go into, but I don't have so much time. But only 8 in 10 trans young people in the UK have self-harmed, and almost half of that attempted to take their own lives. Yeah, as I said, I could go on, but I'm going to move on to the next topic of community. But yeah, we just have so much work to do. That's what I've got to say on that one. Community, I really wanted to highlight. I mean, I'm a big believer in community support. It means everything, and also advocating for others when they can't advocate for themselves. And I think this support really can help process and work through our own stigma, because it decreases these feelings of isolation. And I read a really interesting study also yesterday in Canada that they actually did it on LGBTQ people that also also had a diagnosis of either bipolar or schizophrenia. And of course, what came out of this study was that they felt like they lacked community. They needed these spaces so desperately. They didn't know how to really access them. There was one horrifying remark from one of the participants in the study that said that his psychiatrist made a comment that his feelings of gender dysphoria and potentially that he felt like he was trans was a symptom of a potential episode, which to me feels ridiculous, but yeah, that also doesn't surprise me. Yeah, and I just feel from a personal standpoint that for me, I mean, I'll come to in a second kind of like where I am today and how I take care of myself and my toolbox, but yeah, I genuinely feel like community is as important for me as the rest of my toolbox, which is like I do sport every day. I don't drink alcohol anymore. I take certain medication. I get out to nature. I get enough sleep. I try not to isolate myself. Yeah, and community is the biggest one, and it's been important to me. I'm still on the hunt for it. I think I admire people in my life. My girlfriend, someone very close to me, has such a beautiful community in her life, and they're so supportive to each other, and it's really so inspiring. And I think all of us need this. And of course, when you're in a minority, such as having bipolar or being queer, especially if you're, I think, young, or you're someone that doesn't want to live in a big city and engage in nightlife, because that is where there are a lot of, I would say, people kind of find themselves in these spaces, and I did, and that was my community. And after being very ill a year and a half ago, I had to completely remove myself, and now I'm a big advocate for these safer, not even necessarily sober spaces, but just these other forms of spaces where you can find community, where you don't have to necessarily damage your mental health by engaging in unhealthy nightlife habits. Yeah, there was something else I wanted to touch on, but I've got so many notes here, it's all blending a little bit into one. Oh yeah, the holistic approach. I'm a big believer in this. I mentioned it briefly in terms of my own toolbox, but I think it's interesting. I was reading a paper the other day about kind of adversity to the biomedical model, and it's so medicalized, these conditions, and it's so kind of like there's a checklist, right? Of like, these are your symptoms, this is your disorder. And of course, yeah, it's super important, I think, for treatment to have this to a certain extent. But also, as I touched on, there's the case of atypical presentation where people don't fit into this, and then they get diagnosed years later when things become even more extreme. And this could have been mitigated if there was more research on atypical presentation. Or for some people, medication either isn't their choice, or it doesn't work, or their body rejects it. And in that case, like, what do we look for? And I think that then is where like the holistic approach comes in of, you know, for example, non-Western medicine, Eastern medicine, or like community, and all these things like this, I think are really, really key. I mean, I'm a believer in balance with this. The way I look after myself anyway is very much like a little bit of all these different aspects. But I especially do feel in terms of the medical model, especially in the US, like I read this harrowing statistic in a book actually quite a while ago now, like last year, that like the amount, I can't remember the number, but a ridiculous amount of under 3-year-olds were prescribed antipsychotics. I mean, the pharma industry, obviously in America, is huge, and it's, I think, also a cultural thing. Like in Germany, where I live, it's a bit less. But yeah, there's so many people with trauma that just get forced into the biomedical model without even actually working through or even being asked what's going on, just putting a plaster on that ultimately comes off, doesn't work. So So yeah, that's kind of mainly what I wanted to share. I think the rest of what would like to talk about, I think, can probably come out in the group discussion now. But yeah, thank you for listening and for the opportunity.
Thank you so much, Gabriella. I mean, you kind of said a lot of the things that I was thinking and didn't mention at the beginning, but I think that something that really kind of stuck with me is yeah, it's that sort of isolation, community connectedness stuff, and the conversion therapies. I remember, like, I mean, I should have mentioned this. I published a paper a few years ago on conversion therapies in the trans community. And it was a systematic review, and it found very little. And I think that the thing I kind of mentioned there is that it typically goes under the radar, and I think we need to look at different ways that conversion practices are happening now for the queer and trans community. Particularly like what you mentioned there about that sort of diagnostic overshadowing slash, the sort of, I suppose, the misconception that gender dysphoria could be a delusion or a symptom of psychosis or bipolar or something similar, um, as if you can't be both trans and have bipolar is a ridiculous notion, but it's one used, I think, to kind of silence a lot of people who are seeking help. And similarly, like when it comes to that sort of 9 years for diagnosis, we know that in the UK for trans people, it takes between 5 and God knows how many years to get access to gender affirming services or transition related healthcare. Um, so, I mean, when I'm thinking about sort of experiences of people with bipolar and the experiences of LGBT people, and particularly trans people, a lot of similarities in that sort of like the waiting game that we all seem to go through, and the struggles we go through in terms of not understanding what's happening, ultimately accumulating into worse outcomes. And something I think that both you and Chris mentioned about being in nature, we know that nature is actually incredibly good for mental health. I've got a few friends who have studied nature in terms of as an intervention, and it absolutely does do wonders. But yeah, anyway, thank you. I'm just rambling. Thank you for your talk. I thought it was very interesting.
Thank you.
So we do have about 7 minutes for Q&A. So I think that we'd probably be best to kind of focus on group discussion around this, I think. So one of the questions that came in says, what protective factors, in your opinion, could help reduce suicidal thinking among LGBTQ plus people with bipolar?
I think, I think for me, I think there's two big things. I think one is coming to terms with it, which is hard because it's this thing that you didn't want. And then the other is taking responsibility, again, for this thing that you didn't want. So I think, I think both of those are hard, but I think certainly coming to terms with it is about community, as Gabriella mentioned, and it's finding the others. But I think it's also helpful to realise that it's a really big step to go, I want to get, join a group, or I want to do some individual counselling or whatever. And I think, there's a lot of smaller steps you can do along the way, which is to learn about it either from books or from blogs or from, documentaries and stuff. So I think it's important that everyone's aware that there's a lot of stuff out there to sort of help you get along, and then once you feel ready for more support, and you can go and grab it. But yeah, and I think that's the other point really, is about just taking responsibility for mental health. And the comparison I like to make is with getting fit and losing weight, right? It takes effort. It's not just a case of taking a tablet, it's a case that you've got to make this decision that that's what you want to do. And you know that you're going to have to work at it. It needs lifestyle change. It needs a change in diet. It needs a change in habits. And I think sometimes that can be difficult. So I think there's a couple of things there.
Yeah, I think to lead on from that, for me, it's about early intervention. I mean, I'm talking wide scale now. Early intervention, political aspect, funding, And of course, there's barely any funding in the UK, so of course it all goes to crisis, right? People only actually get help or treatment, however you want to frame it, when they're in severe crisis, which is usually looks like a psychotic episode and or suicidal attempt. So I just think even the fact that that's even the case, it just completely shows how there's absolutely zero funding for early intervention. And like anything, like the earlier people are diagnosed, the earlier people are treated, the earlier people are heard, the earlier people are listened to, the less things can spiral. But I think on a personal level, it's about, as I mentioned, building your own toolbox, doing, I think, a lot of practical things, also like building an episode plan. And as Chris mentioned, like taking care of my mental illness for nearly 2 years after crisis was a full-time job. It's exhausting, and I think I'm grateful that I am a very committed person. I have a lot of inner strength. I know how to advocate for myself. But there's a lot of people, and this does not make me a better person than them, there's a lot of people that don't have access within themselves or to actual tools to do this. And that's why we need to fall on support from the community, which I think in reality can look like support groups, whether it's through charities online, whether it's local support groups, and just having people around you that can stand up for you, that can advocate for you, that can, I mean, I love, for lack of a better term, giving it to my psychiatrist. And saying respectfully, I disagree, but a lot of people can't do that, and so it's having someone that can for
I
them.
think as you touch on there, it's also important to have that plan in place. I mean, it's difficult, when you're touched by mental health for the first time around, but once you've gone through that recovery, it's thinking about, right, once I'm starting to feel those initial feelings or those emotions, what are those, what are those triggers for me to actually have already worked out what your plan is? Because I think sometimes when you're in the middle of it, you don't really want to think about that. You're not thinking in a logical way. So, as you say, to have that thing to go to, which says step one, ring this person, step two, reach out to this organisation or whatever it might be. Think about it for yourself. I think that is really powerful, as you say, around the early intervention piece.
Yeah,
I think
sure.
that's a really good point. I mean, I mean, we've got 1 minute left, but I just wanted to kind of weigh in there because these are some really good steps for like personal sort of advocacy and working on these issues. But there was another question about kind of limited research between bipolar and LGBT identity and suicide risk, and I would say that we need to have more of these conversations, and we need to build a sort of a plan of action. We need a call to action for research as well to help better inform some of the services that people go to have that support. Like what does support look like for people, and how can we improve that? And I think the best way to do that is through co-production and really large data sets. Give me the data of a data nerd, I'll use it all. And that way we can kind of, work together, I suppose, to kind of build that future. But ultimately, as Gabriella said, we need the political power too. And I think that at the moment it is incredibly dire, so it's difficult. But I think ultimately we'll get there with more conversations like this. And on that note, it's now 1:30, so I think we're finished. I just want to say a massive thank you to Gabriella, Chris, and Lauren for joining today. It's been an absolutely wonderful webinar. I've really enjoyed it, and I hope you have too.
Yeah, I loved it. Thank you so much for asking to join.
Yeah, thank you. It's lovely to meet you all and be part of this discussion.
Thank you.
Let's keep talking.
Yes, absolutely. All right. Thank you,
so
everyone.
much.
Thank you for watching, everyone at home. See you
Bye.
soon. Bye.
Ciao.
Bye.